this afternoon's Gastro Echo, which is of course hosted by the GI Foundation in association with Project Echo, the University of New Mexico. So as you know, the Echo sessions are held every week on a Wednesday. Today is our turn, and very kindly our colleagues from KwaZulu-Natal have agreed to share their expertise with us today. So we've got Sean, who's going to give a presentation, and VG is hopefully going to be on. I'm not sure if he is yet, to sort of aid with the discussion. So Sean, I think you can probably start sharing your screen.
Hi, Jill, I'm here. It's VG. It's VG.
Hey, good afternoon. You can hear me?
Yes, perfectly, Sean. Thank you.
Okay, so we're going to talk to you a bit about colorectal cancer surveillance in inflammatory bowel disease this afternoon. I'm going to start off with a short case vignette and then go through a bit of the guidelines and the evidence with regards to surveillance in this specific patient population. So our case is that of a 57-year-old female, Miss CP. She initially presented in 92 with ulcerative colitis, was then diagnosed as having a pancolitis. I started on 5-ASAs, did well, and then subsequently 5 years later was diagnosed with PSC in 1997. Later that year, the PSC progressed and decision was made that she required liver transplantation. She was listed and received a liver transplant towards the end of 97. The following 5 years, she did really well and was maintained on azathioprine for ulcerative colitis and cyclosporin A. In 2012, the cyclosporin A and cyclosporin A was changed to tacrolimus. And since then, she had a fairly mundane course of a disease. However, in 2017, she presented with worsening jaundice and had now had recurrence of the PSC. Her medication was optimized, and for a while, the disease remained stable. But later that year, she was then diagnosed with renal cell carcinoma. And towards the end of that year, she had curative surgery with a partial nephrectomy for the renal cell carcinoma. Subsequently, her screening colonoscopies just again showed this small colitis with no other real symptoms. Then that COVID-19 pandemic occurred between 2019 and 2021, and she missed her subsequent follow-up colonoscopies. In early 2022, she presented with worsening jaundice. Repeat MRCP showed a sclerosing cholangitis, and biopsies then of the graft showed that she is developing worsening PSC, but no real evidence of failure of the graft. Decisions was then made on should she be relisted for retransplant. However, her ulcerative colitis was fairly mundane at that stage. In early 2013, she presented with fever, and during the course of her workup, she was diagnosed with a colorectal cancer in the right side of her colon. Early in the year, she underwent a proctocolectomy and completed neoadjuvant therapy, and is currently doing well post-surgery. So this clinical course might be a familiar course to some in the audience. There's also a topic of colorectal cancer and inflammatory bowel disease. Now, colorectal cancer and inflammatory bowel disease, there's an inherent risk of 1 to 2% in patients with inflammatory bowel disease as compared to the general population. For sporadic colorectal cancer, it accounts for about 15% of all deaths in inflammatory bowel disease, and the incidence rate is about 18% in 30 years of colitis, with a risk that increases between 0.5% to 1% yearly after 8 years from the first diagnosis of ulcerative colitis or a colitis. Most guidelines recommend that the screening should be done onwards from year 7, and there's variations in regards to which type of follow-up should be done. This cartoon illustrates the differences in pathogenesis in colorectal cancer development in patients with inflammatory bowel disease, as opposed to patients that follow the normal adenoma to carcinoma pathway. Here you can see that in a non-dysplastic IBD mucosa, there's persistent inflammation with drivers of inflammatory markers, and this over time leads to loss of tumor suppressor genes such as P53, and then the development of this low-grade dysplasia. And again, over time, with the ongoing inflammatory changes, some genetic risk factors, environmental risk factors, that then can develop to further loss of further tumor suppressive genes like the KRAS, and then you get development of high-grade dysplasia, then ongoing inflammation drives angiogenesis until you get this sort of awkward colorectal cancer that occurs in these patients with inflammatory bowel disease. In saying that, the risk factors for the development of colorectal cancer in patients with inflammatory bowel disease is inherently different to those of the general population. And this can be divided into 2 broad categories: those that are associated directly with the effects of the disease, such as the duration of the disease, severity of intestinal inflammation, presence of pseudopolyps, chronic strictures, and then a foreshortened colon. Epigenetic risk factors can be sort of classified into those patients that develop PSC. We've seen in a previous talk that the odds ratio is about 5 when the 2 are combined, family history, and in patients that have a younger onset of age, that the diagnosis of the first colitis is an inherent larger risk for development of colorectal cancer. Now, this table illustrates the different recommendations from different societal guidelines over the last few decades. And if you look at the table, we can see that the American guidelines, this is American Clinical Guidelines for ulcerative colitis in 2019, all the way through to the American Gastro Association guidelines, their variation for screening is between 1 and 2 years with regards to surveillance. And then there's some amendments with regards to the extent of the disease. If the disease is beyond the rectum in ulcerative colitis, the screening is recommended for around 2 years. And if it is limited to proctitis, it can be up to 3 years. The American Gastro Association further goes and said that if the examination is negative after 2 exams, you can extend that surveillance for another up to 3 years. If you look at the European guidelines, they differ slightly, and I sort of lump them together, the British Society guidelines, ECHO, and the NICE guidelines, because they're fairly similar. They sort of lump them together in 3 broad categories of having a low-risk patients group, and you can see they've recommended that you go up to 5 years with regards to surveillance colonoscopy in these patients, an intermediate risk group, and then the high-risk groups is that for annual. Those are patients that have PSC, additional familial risk factors, and where there is an extensive colitis. This low-risk group is patients that have a limited proctitis and that has responded well to 5-ASA therapy. Now, this confusion and non-conformity to guidelines has led to various adaptations for screening and surveillance in this particular population. So this led to a working committee to come together and come up with a scenic recommendation. So this is the screening of colorectal endoscopic neoplasia in patients with inflammatory bowel disease. And this table summarizes the 6 main recommendations that the scenic working group came up with in 2015. And these recommendations, again, was based on available evidence and use of available equipment. In 2015, when these guidelines were formulated, the uptake and use of high-definition colonoscopies in the United States was around 56%, and in Europe, it was around 62%. So at that stage, most centers were using standard definition colonoscopies, and you can see that the recommendations are heavily weighted towards standard definition colonoscopy scopes being used. Main recommendation was that colonoscopy should be used for surveillance with regards to screening for dysplasia, and when colonoscopy is used, chromoendoscopy should be used as an adjunct during your colonoscopy to identify lesions. Further recommendation was that after 7 years, all patients should have a surveillance colonoscopy, and then biopsy should be done every 4 centimeters, 4 biopsies every 10 centimeters on contiguous colon. Importantly to note that there was no recommendation with regards to the use of image-enhanced high-definition colonoscopies, narrow-band imaging colonoscopies, as well as virtual chromoendoscopies. That working group also decided to standardize a definition for dysplasia, and it was a sort of adaptation from the Paris classification, which we're all familiar with for the diagnosis of polyps. But they also re-advocated the use of the Kuro-Pitt pattern recognition in these patients. So what they did was they subdivided the dysplasia classification into visible dysplasia, whether it's polypoid, non-polypoid, flat lesions, and then invisible dysplasia. And the recommendations for the presence of polypoid or non-polypoid lesions was based on the size of the lesions and the resectability thereof, whereas invisible dysplasia that was defined as dysplasia that was found on random biopsies, now targeted biopsies, and the colonic mucosa. The management there we'll discuss later. Again, as mentioned earlier, the management of the dysplasia is dependent on the polyp that is seen, if it's polypoid or non-polypoid. Endoscopic management was recommended, and this was then followed up with colonoscopy, surveillance colonoscopy, as opposed to colectomy. However, for patients with invisible dysplasia, these patients needed to be tightly or closely followed up, and there was no clear recommendation as to a timeline as to when, whether it should be done within 3 months, 6 months, or 1 year post identification of this invisible dysplasia, and what the further management should be for these patients. The slide is just to sort of summarize what I've said regarding this dysplasia. So if at endoscopy you found visible dysplasia, and this is dysplasia that was not involving colitis, that should then be managed following standard polypectomy techniques, and the surveillance is then based on the outcomes of the histology in that specimen. If it was invisible dysplasia, those patients you would then refer on for a repeat high-definition colonoscopy, and the high-definition colonoscopy had to be done with the addition of chromoendoscopy. And if lesions were then identified, they were then managed on the basis of could they be managed endoscopically or should they be referred for proctocolectomy, and then surveillance is based on the outcome of that histology. I mentioned dysplasia was the key word from the original 2015 guidelines from CNIC. And invisible dysplasia, the issue with it is it has a high rate of synchronous colorectal cancer. In low-grade dysplasia, it's up to 22%, and up to 65% in high-grade dysplasia. The important part, though, was that most invisible lesions that were found are detectable on high-definition colonoscopy with the addition of chromoendoscopy. And these patients require close follow-up, and from the moment that this diagnosis of dysplasia is made, the patient should be counseled, and they recommend that early recommendation for proctocolectomy should be undertaken. However, surveillance colonoscopy should be performed in these patients as opposed to direct colectomy, unless there is high-grade dysplasia that's found in this patient. This is endoscopic images. The image on the right is that of white light high-definition colonoscopy, and you can see in image A is clearly a lesion, but you can't define the borders. When narrowband imaging is applied, the borders of this lesion is defined, and you can then plan for endoscopic or non-endoscopic resection. In this particular image, this lesion was resected endoscopically with the aid of narrowband imaging to mark out for the ESD that was performed in this patient. Again, these endoscopic images in image A, you can see that on high definition colonoscopy that there is clearly a lesion that is present, has a bit of a raised edge. Image B has the application of a dye. The dye here is indigo carmine that is being used. And once the dye was applied, you can clearly see that there's a depression of demarcated area. And image C is just the magnification of this demarcated area that you can see. And D is then the histology of this resected lesion that clearly confirms demarcated area with submucosal invasion. So the guidelines was clear for its use and its rollout, but since its rollout in 2015, there was poor adherence to them. And Santi and his colleagues surveyed 8 Swiss centers, and they found that only 7.4% of all endoscopists that were doing screening colonoscopies for patients with inflammatory bowel disease used chromo endoscopy. The same was found by Sonozaki and his colleagues, and they surveyed 541 gastroenterologists, and less than 50% of them adhered to this recommendation. And the big issue with adhering to the recommendations was, number one, technique. And the technique was these endoscopists were not trained in the use of chromo endoscopy, and when chromo endoscopy was used and applied, whether or not it was used in the correct setting. The other issue was length of procedures. Colonoscopies ended up being extremely long, purely surveillance. And most endoscopists felt that doing 32 biopsies, 32 biopsies for surveillance was not the best use of time. So then Wantabi and his colleagues published a paper in 2016 where they looked at targeted biopsies and compared to random biopsies in these patients with inflammatory bowel disease. And they randomly assigned 250 consecutive patients that had a history of ulcerative colitis to either have random biopsies or targeted biopsies. And the targeted biopsies were done using narrowband imaging or chromo endoscopy. The bar graphs to the right shows that there was no actual difference with regards to the dysplasia detection rate in both the targeted or the random group. The benefits of the targeted group was that the procedure time was reduced by up to 7 minutes, and the random biopsy group or dysplasia that was detected was from areas that had previous inflammation. And the way they got that information was every biopsy specimen that was submitted, they had to inform the investigators where it was taken from. What about the combination of targeted biopsies with chromo endoscopy? So Yang and his colleagues found that chromo endoscopy showed an improved colorectal neoplasia detection rate compared to high definition colonoscopy. Alexanderson and his colleagues found that chromo endoscopy identified significantly more patients with dysplasia than did high definition endoscopy with only the use of white light. The neoplasia detection rate was found to be no different in patients that had undergone chromo endoscopy with either ethylene blue or carmine indigo or narrowband imaging. And the benefits again was there was this absolute reduction in procedural time, on average about 7 minutes shorter, as found by Bishops and his colleagues. This thing, though, the recent study showed that high definition colonoscopy and virtual chromo endoscopy again showed no difference in the detection of dysplasia. The absolute numbers in the study by Gandaya showed that there was a higher number of patients that had dysplasia in high definition with white light colonoscopy. This was found to be not significant in that study. So since 2015 up until recently, there's been many studies that have looked at the use of chromo endoscopy, standard definition colonoscopy, and high definition colonoscopy, as well as how they compare with regards to the dysplasia detection rate. This meta-analysis by Feinstein showed that the addition of chromo endoscopy to high definition colonoscopy had a higher identification rate, efficacy rate of event rate when standard definition colonoscopy was used on its own, or high definition colonoscopy we use with white light endoscopy. The combination of high definition colonoscopy with chromendoscopy is seen to have a higher impact rate. A network analysis was then also performed looking at virtual chromendoscopy in the detection of patients with dysplasia in ulcerative colitis. And here again, you can see that the odds ratio of narrowband imaging when compared to your other modalities such as chromendoscopy with high definition endoscopy and white light endoscopy was significantly higher. The odds ratio of around 5.7 with detecting dysplasia in these patients. And when the rank probability was performed, again, narrowband imaging outperformed, with the addition of high definition colonoscopy outperformed the other modalities in detection of dysplasia in these patients. So since then, a lot of information has been published, and there's been a few meta-analyses that has been done with regards to dysplasia detection rate in patients with inflammatory bowel disease and the use of high definition colonoscopy. In this table, you can see that the CINIC recommendation in 2015, the original recommendation was that high definition colonoscopy should be done for dysplasia surveillance, and that has not changed with the updated guideline. But what has changed is the addition of targeted biopsies as opposed to random biopsies for the detection of dysplasia in those patients when you are using a standard definition colonoscopy. So when the guidelines got re-looked at, the uptake of high definition colonoscopies or colonoscopes had changed about 86% in the United States and to around 90% in Europe at time of reporting of the updated guidelines. In saying that, the use of your virtual chromendoscopy, narrowband imaging, as well as direct spray chromendoscopy with targeted biopsies was added as all an accepted modality for screening and surveillances in patients when using high definition colonoscopes. This was not part of the previous guideline and was added on the basis of evidence provided. They also added a sub guideline to this and noted that when these modalities are used, the endoscopist should be trained in the use of narrowband imaging as well as virtual chromendoscopy with regards to improve their dysplasia detection rates. And again, you can see that previously this was not included into the guideline. So again, it's a lot of information regarding who do we biopsy, who don't we biopsy, and how do we follow them up. So in simple terms, if you have a patient that's got inflammatory bowel disease, ulcerative colitis, and it's been prolonged disease, the recommendation is that at 7 years, you should proceed to surveillance colonoscopy in these patients. If you have a high definition colonoscope that you're using, then you should be using narrowband imaging, virtual chromendoscopy, or white light endoscopy with targeted biopsies of suspicious lesions, provided that there is no evidence of colitis. Once that lesions is reviewed, the patient then gets individualized risk assessment. And based on the individualized risk assessment, the follow-up surveillance colonoscopy is then planned. It's a high-risk patient, in other words, there's presence of PSC, family history. Patient should have an annual colonoscopy as opposed to colectomy for surveillance. However, if it's a low-risk patients, you can go ahead with using the same screening modality that was used before. In a setting where you're still using standard definition scopes, which might be applicable to our setting, where certain centers might still be using standard definition scopes, you are then obliged to use direct spray chromoendoscopy. And you either have to use methylene blue or indigo carmine. But as opposed to previous recommendation that recommended that you use random biopsies, you can now go ahead and do targeted biopsies, provided that there's no colitis present within any of those lesions that you are biopsying. I think that's the last slide. Thank you. I'll hand you over to VG.
Hi, Sean and other members of the audience. Yes, Sean, I think that was a very comprehensive and concise review at the same time. And I think we really want to highlight that there's areas that are still fairly unclear, especially with regard to the sort of intervals of how frequently one should do a scope on these individuals. Now, in years gone by, if we found any degree of high-grade dysplasia, whether it was visible or invisible, the recommendation was, offer the patient a surgery, colectomy. That's obviously now somewhat changed. However, I think it depends on, and I think Sean highlighted it, you have to individualize everything. And for us, we would still offer such patients with high-grade dysplasia, especially if they've had ulcerative colitis for a long time, of over 15 years, 20 years or so. And we would still actually offer them a surgical review without consult. But I think things have changed where you should offer it, but at the same time, you can offer them the option of more closer and intensive surveillance. The problem we have right now is, what is closer surveillance? Should we do a repeat scope in 6 months? Should we then do them annually? And after 2 scopes with these random biopsies, should we then say, okay, now we can follow you up with a surveillance by colonoscopy every 2 years, every 3 years? Remains unclear. And if you read some of the patients' websites where they have provided advice with this in this particular regard, they normally recommend something like that states you should have regular colonoscopies. Now, how much is your regular? Again, is a bit unclear. For us, how long somebody has had ulcerative colitis, it also influences the frequency of our how frequently we do colonoscopy surveillance on them. And if you've had and our general rule was, yes, we start screening after 8 years. We do the first surveillance colonoscopy, and if all of that's okay, including those random biopsies, 4 quadrant biopsies every 10 centimeters with careful inspection, then we would probably, provided the patient is in endoscopic remission, there's virtually no minimal inflammation, we will probably then repeat that scope in that patient for surveillance after about 2 to 3 years. But when a patient now has ulcerative colitis, a pancolitis for more than 20 years, more than 20 years, we will then usually increase the frequency to annually. Now, of course, given our load of IBD and the other scopes we have to do, that isn't always feasible. But generally, once they've had ulcerative colitis for more than 20 years, we generally do offer them far more frequent colonoscopies. Once again, certain individuals don't want to have regular annual scopes, colonoscopies. They have no or very little intestinal inflammation. And in those patients, we can sometimes say to them, okay, so we can't do it every year because, you don't want to have it, but you're at, low risk. So maybe we'll try every 2 years or every 18 months. So again, it's coming down to trying to individualize it. And what's primarily key to individualizing it is, as Sean showed earlier, what actually drives the neoplastic process is inflammation. So if you get an ulcerative colitis patient and you control their inflammation and you're able to maintain that endoscopic remission, there is clearly you will reduce your risk of developing IBD-associated colorectal cancer. Of course, you must look at their family history, etc., and if they have a associated PSC, which is puts them in a higher risk sort of group. Now, I'll return to the audience. I think Sean sort of went through chromoendoscopy, narrowband imaging. I have my own views over there. And I think one of the studies that Sean highlighted was everybody, when you read articles on how to survey people, everybody highlights chromoendoscopy. I'm assuming our units in even here in South Africa are now HD sort of ready, and almost all our scopes, and if you do purchase a scope now, almost all of them will be HD. So the problems I have is, nobody is performing these 4-quadrant biopsies every 10 centimeters up to 32 random biopsies. I remember at the stages Congress years ago, 2006, there was an overseas speaker, Professor Guido Edgard, who actually asked the audience, who here in this audience is actually sitting and performing these 4-quadrant biopsies? And being rather naive, I actually raised my hand. And I was the only individual in the audience who raised my hand at that over there. And but obviously, I was sort of saying, yes, I'm trying to do it, but I'm spending hours doing scopes and taking these 4-quadrant biopsy. And as the years go by, I'm fairly certain that very few people are performing those 4-quadrant biopsies. Do you have anything to add over there, Jill, regarding how you guys do surveillance and how you're adhering to that 4-quadrant biopsies and doing chromo as well?
No, so I don't think I agree with you that it's actually impossible to do 4 biopsies up to 32 biopsies. I think that has long not been practiced. Majika may want to add in here, but chromo is just a little bit lengthy to do it directly. So I think narrowband is probably the easiest and high definition. Just one point I did want to make, I don't think Sean touched on it, was that when you survey somebody with IBD for colon cancer, try to do it wherever possible when the patient is in remission, because otherwise you get that horrible report coming back which says regenerative atypia or indefinite for low-grade dysplasia, which is a little bit of a nightmare. I know it's not always easy to do these things when patients are in remission if they have long-standing disease, but if possible, I think that is the way to go. Mash?
Thanks, Jill. Thank you, Sean and VG. The patient has had such a troublesome progress. But I do agree with Jill that we tend to do high definition with narrowband and targeted biopsies. We would long have stopped doing a chromoendoscopy with dye. The issue that I have with the guidelines is all of them imply that you will only biopsy targeted lesions if you see them. And the question has always been then, if the colonoscopy is completely normal, assuming adequate bowel prep, and as Jill has said, the patient is in remission, do you still take biopsies, random biopsies? And I'd say my practice is that we would still do random biopsies if the colonoscopy is completely normal, because it is still an opportunity to assess for microscopic disease. But I find that the guidelines don't specifically address that. They only talk about targeted biopsies should you see non-normal looking mucosa. Jill, would you agree with the practice of biopsying if everything looks otherwise normal?
Absolutely, Mash, because we know that the ESG guidelines that we follow, even if it actually looks macroscopically okay, if there's still some degree of microscopic inflammation, it is a slightly warning trigger. There's a question on the chat, which is a very interesting one, and it's a really difficult one to answer. So I'm going to throw it out to VG, Sean, and Mash to see what your thoughts are. It says, thank you very much for the comprehensive talk. For patients with multifocal low-grade dysplasia confirmed by chromoendoscopy, should I go for colectomy or for intensive surveillance? I've got a very strong thought on this, but I'd like to hear your guys' view first.
I think I'll start with Sean. Sean, I think we spoke about when we were going over this, we just briefly spoke about this, so maybe you'd want to answer that.
Yeah, the issue here is this invisible dysplasia, and unfortunately for this patient, the recommendation is that you're either going to repeat this scope earlier or offer the patient a proctocolectomy. So because it's multifocal low-grade dysplasia, there's that inherent risk. You should sit down and counsel that patient with regards to having a proctocolectomy. The other option is you can discuss with the patient, and the patient might not want to go down a surgical route, having repeated scopes, but then you're going to have to do it at 6 monthly intervals until there's nothing, and the patient might actually not want to have, I think, 4 colonoscopies in the space of 2 years just to go and confirm whether there's high-grade dysplasia or not. So this, you're going to have to sit down with your patient and really certify and individualize for that patient. But currently, most patients would probably opt to have a colectomy as opposed to having multiple colonoscopies in the space of 2 years. Yeah.
Yeah, but of course, you know, I mean, I don't think many of our patients look forward to either having a scope or surgery, and people generally want to keep their, like, you know, colons by and large. I have regarding what was asked there. Firstly, for patients with, it actually states in that question, low-grade dysplasia confirmed by chromo and endoscopy. Firstly, low-grade dysplasia, although we want to believe we're in that age where we can make a histo-like and diagnosis using our scopes, I think when we say someone's got low-grade dysplasia, that usually comes from our lab, the pathologist. The chromoendoscopy sort of just indicates to us this area looks abnormal. And yes, now with the AI, and if you've got a highly sensitive eye, you may be able to say that this looks abnormal. But I think for you to say on chromo that this is low-grade dysplasia, it probably needs to be rephrased the way that's asked, right? Also with NBI, now this is one of my other concerns. When NBI first came onto the scene, looking at the sort of upper GI tract primarily, NBI stands for narrowband imaging, and all NBI is a filter. It filters out, you know, red light versus blue light, and you can alter it and play around with it. And NBI was originally from Olympus. The other manufacturing companies now have their eye scans, Pentax, but it all works more or less on the same principle. It's a filter of, like, sort of, you know, light. And what that filter is going to do is it's going to highlight vascular structures. So it highlights the, like, microvasculature. Now, in IBD, this has always been the issue in doing surveillance with NBI. Is that the vascular like a pattern may be altered just from the scarring and inflammation one has with the IBD. So it's always been an area where should you even be using NBI? And the studies that did use NBI for this particular indication said, oh, well, it's almost as good as chromo, but the earlier studies did not show that. They show that compared with the HD, NBI didn't add anything. But subsequently, again, it's shown that, oh, you can use NBI. What I feel is that because these patients or these people are enrolled in a study and they're aware that they are being compared, you are probably just staring more like closely. You're just paying a lot more careful attention. So for me, if you have a very good HD scope, clean prep, and as was pointed out, no inflammation, no endoscopic inflammation, that is probably adequate. If you have the NBI, go ahead and use it, but it still means you must just inspect carefully, and the adding on of NBI probably forces you to inspect a bit carefully and find these areas that are abnormal. I don't know if Jill or Asheka wants to add anything over there, because it's just one extra thing I want to speak about, separate from the issue of screening itself, but related.
I think you've pretty much said it all. VG, there was just a bit of an addendum to that question.
Yeah.
Multifocal dysplasia confirmed by 2 pathologists. I'm not sure if that really changes the scenario, because
No. I think I was just being a bit pedantic about how it's worded, because I think we have to be careful that yes, we have these scopes that are excellent and we see the vascular pattern and the Kudo pit pattern, but we still rely on our histo to definitively say this is dysplasia. The other issue is before the patient even reaches that stage of surveillance and we find an early cancer. And as Sean pointed out, inflammation drives the risk for your cancer. And one of the things that's often been a conversation, and we know that the rates of cancer in IBD patients, in ulcerative colitis especially, have been reducing, going down. We're finding fewer and fewer of cancer, and I'm sure you guys also, where we go and do these hundreds of surveillance coloscopes here, and we rarely find anything. We're often surprised when we get back a biopsy report saying, "Oh, there's high-grade dysplasia here." Now you need to have that conversation with the patient. Do we keep individuals who are in endoscopic remission who are on other agents, like one of the either infliximab or TNS or small molecules? Should you still keep them on 5-ASA for this role of chemo prevention? I would say no, because if they're on a drug like tofacitinib, although I don't have any experience with it, and they've been in endoscopic remission and quite stable on it, or they've been on infliximab or adalimumab and endoscopically in remission, fecal like calprotectin low, is there any role to just keep them on a low dose of a 5-ASA with this belief that you are going to prevent cancer? Right now, the feeling is no, but I want to hear how you feel, Jill. Do you still keep some of these patients on a little bit of 5-ASA? It's hard to stop when they've been on it for years, huh?
So obviously we have learned over the years, as you've alluded to, both of you have quite clearly described this, that it's inflammation that drives the cancer. So probably 5-aminosalicylates do not provide an independent effect on reducing colorectal cancer, but their benefit is really in just reducing inflammation. So if we're looking at a patient who's in deep remission and they're on a biologic, not sure about tofacitinib, I'm not sure if there's any data on that, but certainly if they're on an anti-TNF, there's no reason to continue them on a 5-ASA. It's just really about controlling inflammation. I'd just like to make a comment as well about the question that was put about the multifocal low-grade dysplasia. In my opinion, multifocal low-grade dysplasia, it's a no-brainer, it's a colectomy.
Yeah, I would have to agree with that. And also, I think you raised the important point, Badreddin, of having a GIT pathologist. So the diagnosis does need to be a firm diagnosis of low-grade dysplasia. We've had many cases that we've discussed at our MDT where it was reported routinely by other pathologists as low-grade dysplasia. I'm not talking about multifocal, but just low-grade dysplasia. And then our pathologist will actually review the slides and actually not call it that. So I think you need a good team of gastroenterologists, you need good equipment, but you also need a pathologist with ideally a specific interest in this sort of thing. But I would agree with Jill that for multifocal dysplasia, the bias for me certainly would be towards colectomy. I would advise the patient for that.
Absolutely. And a single focus of high-grade dysplasia that is not endoscopically resectable, in my opinion, is also an indication for colectomy.
No, 100%. And VG, I also would agree with Jill that learned that it really is about controlling inflammation. It's not so much about specifically the 5-ASA compounds. And even, we've talked about the use of aspirin as a chemoprophylactic agent, but that doesn't come into the picture. Controlling inflammation with whatever agent and monitoring the patient and confirming remission. That should be sufficient. VG, I have a question for you guys. So I have two comments or questions. The first is the incidence of renal cell carcinoma in patients with IBD. Have you come across any data that says that there is an increased risk in these patients with IBD, or that was just an incidental occurrence in this unfortunate patient?
Yeah, hi, Prof. I think I can answer that one. It's the latter. It's an unfortunate occurrence. We didn't really find anything significant in if you look at a clinical course over the last 25, 30 years, she's just been unfortunate with the events that has occurred. And unfortunately, well, fortunately for her, every time she has this, whichever event occurs, she's so full of good spirits that she overcomes it. And you can see with the timeline, she has this period of a 5-year gap where nothing happens. But when something goes astray, it's quite major, But to answer the first question, it seemed like it was incidental. Some case reports initially we found, but nothing firm that I came across.
Yeah, but remember, she was also on immunosuppression for transplant, long-term tacrolimus, and how she presented, how we found the renal cell cancer is actually interesting. She had some worsening of her, jaundice, cholestasis. So obviously we get concerned about some cholangioCA in the transplanted liver, or just a worsening of the PSC. So this was just on a follow-up MRCP. So she had an MRCP, and there was an incidental lesion seen in the in kidney.
Yeah.
So she was actually fortunate that she had an MRCP. And then we said, wait, but now what's going on here? And one thing leads to the other, and she needs a nephrectomy, and she's been okay since then.
Yeah.
So I think it was more related to immunosuppression rather than the IBD itself.
Yeah.
But if anyone else has anything to add on that, well, did you ask something else?
No, so I mean, I haven't read this in a while, but there are case reports of an increased risk of renal cell carcinoma in IBD cohorts, but usually patients with Crohn's disease. So I guess I would have to agree. It's not a direct association that I'm aware of. Jill, would you agree with that?
Yeah, not a direct association with IBD itself, but certainly the thiopurines, and she was on azathioprine. I can't remember if that was before or after she developed the renal cell cancer, as is associated with an increased risk of urogenital carcinomas, particularly bladder cancer.
Indeed, yeah. And then Jill, I'm not Jill, VG, my final comment was not in a patient with PSC. So let's say you've got a patient with IBD and they have colitis, and they are in remission in terms of your biochemical markers clinically, etc. And at the last scope that was done, there was endoscopic as well as histological remission. And now the patient does not want to have repeat colonoscopies at the said time periods. Is there any role for a fit in this patient?
Yeah, that's a very good question. I don't have a clear answer on that, but it's quite rare for our patients to say they are adamant that they will not ever have a colonoscopy. What they do ask for is, can we throw it out a little bit more? So rather than annually, maybe 18 months. So we sort of sit down, and again, we individualize it. It's not going to be the end of the world if we wait an extra 4 months or 6 months. For me, doing a fit in that group of individuals, I mean, there's a very high chance, even though you went ahead and scoped the patient and you didn't see anything obvious, it's unusual that, a patient with known ulcerative colitis is going to have 1 or 2 small erosions. That's going to give you a fit result positive, but it's not something I've actually looked at. I really don't think that's a role for fit. I don't see a role for routine fit testing in IBD. but as we pointed out throughout most of this presentation, in all aspects, this is becoming an area where you are starting to, rather than placing out recommendations and or strongly worded guidelines, you are going to start to individualize it. So maybe you might have one or two patients in your GI clinic that absolutely hate having that clean prep and colonoscopies. And you say, look, I've done a sigmoid on you. You look like you're an endoscopic remission. We need to survey you. We'll offer you this FIT. But remember, if it comes back as like positive, you know what's going to happen. You're going to need a colonoscopy. So will they be happy to? They must also be happy to have that colonoscopy after that FIT result. FIT is high, but at the same time, FIT is very sensitive. It's highly sensitive. So there is probably more value in that FIT being like normal, that there's no evidence of it might just be a bit more reassuring. But again, I haven't seen any recommendation regarding FIT in IBD, in a non-IBD. Have you come across anything?
No,
I think it
definitely
was negative. You didn't feel better anyway. I think you'd still do the colonoscopy.
Just a comment there. I think artificial intelligence is going to change this all completely. As you say, VG, that will give us a personalized approach. Once something has been resected, it'll spit out some kind of a probability of what one needs to do, what the likelihood of there being further lesions is. I think things are going to change with that.
Yeah, and also if I return to this question that's up there on the chat, and I heard you and Jill saying, no brainer, this patient must go have a colectomy confirmed by 2 histopathologists. But over the years we've had a few of not a hell of a lot, maybe 2 or 3 patients. Yes, and each person was completely different. Some said, you know what, I'm very reluctant to have an operation. It depends on your surgeon as well. If you've got a surgical department, I hope there's no surgeons on this, but if if some of these patients have heard, and they see other patients who've had a subtotal colectomy or something, and they hear about some complications, they may be averse to having an operation, unless they absolutely have to. So you have some patients who are very risk averse. They don't want to go anywhere near the operating room, and they're happy to have that more frequent scope. And then you have the other end where somebody says, here's the word possible, like cancer, and they're not hearing anything after that. They're going to have their colons out and they want to go to the operating table that same day. So yeah, so you have to, it depends on your appetite for your risk. And I don't mean your appetite as the physician, but the individual that you are seeing to. So it comes down again to offering them the information and the options.
Yeah.
Absolutely, VG. And just another comment that you made earlier about the incidence of colorectal cancer coming down. So when I was training, which was quite a long time ago now, we were taught actually that the risk was 10% after you'd had disease for 20 years, which was fairly horrifying. So I think that data came from the old sort of tertiary institution, referral hospital. And then as those big Scandinavian databases started producing results, it seems to have come down and possibly also as a result of better treatment controlling inflammation. So it's not nearly the problem that we thought it was 20 years ago.
And we are treating it better with more, we are treating it harder and we are doing surveillance a lot better. So I think a lot has improved on that sphere. And I was going to say that we surveil all the time, but we don't pick up a lot of these patients. I wonder if that's your experience, VG.
Yeah, that also is our experience, and I think I even remember a little abstract from a few years ago. I can't remember where it was at some at a UEGW or ECHO. I think I was just reading through the abstracts, and there was one really excellent one that really brought into this whole question about if somebody is in endoscopic remission, do we really need to be surveying them every 3 years, because they followed up a group of individuals who were in endoscopic remission for a long period of time, and they just didn't find anything. The rates of low-grade dysplasia or high-grade dysplasia were incredibly low. And again, if you have a department that's doing lots of colonoscopies for patients with symptoms, symptomatic individuals, you really need to bring down your load of surveillance colonoscopies for IBD. And that may be a group of patients who are in endoscopic remission that you can say, look, we really don't need to survey you as frequently. Maybe we can throw it out. So I can't remember the abstract offhand, but I think it provided good evidence that in those with endoscopic remission, you probably can survey them less frequently. I really don't know if the audience has anything to ask. I mean, all of y'all are forced to do these surveillance colonoscopies and spend hours staring for areas that are abnormal. Do you all have anything to ask? I mean,
Sean, I take it this patient did not have any dysplasia on any of the biopsies pre-COVID.
No problem. Her at the worst that she had was a Mayo 2 colitis that was prior to her, prior to the scope she had in, when was this? In 2017. Other than that, she was actually quite fine. So, yeah.
Sean, do you want to briefly, oh, by the way, I do know this patient. I've, ever since I started, she's been in the GI clinic. She had a transplant years ago. She's actually done fantastically well. She's one of these long she's had TB a few times, cellulitis, but she's done very well. She still rides horses in Hillcrest. She had a very interesting, and she hates having surveillance colonoscopies. I have to sit there and negotiate with her and tell her about the and she says she knows, and she comes. So when we had COVID, she was happy because this was an excuse to avoid colonoscopies and coming to the hospitals because I'm a transplant patient and I was scared of COVID. And so she said, no, I don't want to come in and have anything, we all locked down. She locked herself down, and she was fairly happy to stay at home. But Sean, you just want to highlight how she actually presented. She didn't actually present with any GI symptoms, huh?
Yeah, so she actually was scheduled for eventually after we convinced her for her surveillance colonoscopy in, I think, May or April of this year. However, she came with fever. She presented with this non-specific fever, had rigors. It was a waxing and waning fever. Initially, we were worried that she's got a cholangitis. Looked, didn't find anything, didn't grow anything. Send her off, and the fever would settle. Then she would come back a few weeks later, fever again. Kept on looking, we're a bit worried that there's abscess formation that's happening. Ended up worried about this previous renal cell carcinoma. Screening, looking for evidence of that recurring. Again, just fever, no recurrence, never grew anything. And then we sort of caught between a rock and a hard place, because she kept on coming in. She had quite of bird fevers with rigors and sweating, that she ended up having a PET scan, which is unusual for fever. And the PET scan showed a small focus of increased uptake in the right side of the colon. And this happened a week and a half just before she was supposed to have a screening colonoscopy. And then we found this sort of polypoid, almost 2 centimeter lesion. And then from there, diagnosed and sent off to have a colectomy. It was quite a strange presentation.
Wow.
Yeah, basically she presented as fever of unknown origin.
Very interesting.
Joe, did you see the question from Chris?
Well, is that one from Chris? Very nice presentation and discussion. Thank you.
Yeah, he says, the introduction of biologics impacted on the surveillance and incidence of colorectal cancer in IBD.
Yes, absolutely. So the incidence has come down, as I said earlier, from what was meant to be about 10% to 20 years, that would have been in about 2006, now to way, way, way under that. So the two things, as I said, that have been the cause of that, one is that we're now using population-based data as opposed to referral center data. And the second is much better improvement in inflammation control with biologics and some of the newest small molecules, because the cancer is entirely driven by inflammatory activity.
So it's not just the introduction of good Scandinavian databases.
No, no.
No, I would also say it isn't just for the treatments that we have available, but this whole idea of achieving endoscopic remission. Now, when I first started as well, Jill, we were just happy if the patients had 2 or 3 stools per day, once or twice a little bit of blood. Oh, you're doing fine, you're okay. But now, because we're aiming for endoscopic remission all over the place, how you achieve it, whether it's with biologics or higher dose 5-ASA, as long as you're getting endoscopic remission, I think that's made a big difference. Our change in mindset. Yeah.
Totally. I mean, I know I trained before you, but back then I'd call a consultant and they'd say, please treat the patient, not the scope. So how things have changed in 2 decades. Yeah. Mash, I do think we're running over time, eh?
Okay. All right then. Thank you so much to Sean and VG, particularly because you came to the rescue at a very, very short notice. I really, really appreciate that. And thank you for the fantastic case presentation and clinical discussion of really a very, very important topic. I also want to thank ECHO at the University of New Mexico, Cheryl, Karen, and then the ECHO India team, who are always in the background doing what they do. Do remember that the recordings are available on the Gastro Foundation website. They're very easy to find. The website is actually laid out quite nicely. So they're there for you to review at any stage. Thank you to the Gastro Foundation and the continuous support to education, to our fellows and all the gastroenterologists. Thank you to my co-chair, always a pleasure. And of course, without the sponsors, we would not be able to host these meetings. Be reminded that next week's offering is pediatrics. So please join if you can. Thank you once again. Stay warm and have a great evening.
Cheers, everybody.
Thank you.
Cheers. Thank you.